Healthcare costs, particularly the cost that Americans pay themselves, is one of the top domestic policy issues. Whether you're Republican or Democrat, from management or labor, every stakeholder seems to agree that we are spending too much money in America on healthcare because we're not delivering in terms of individual and population health. So as pressures come from all sides to reduce healthcare expenditures, there is really an interest to buy less of everything and lower the price of everything. And as a physician, I did not go to medical school to learn how to save people money. I went to medical school to learn how to make people healthier and improve their well-being. So I tie my clinical training with what I do as a researcher to come up with an alternative to, say, cutting everything to possibly preserve the health of Americans as we deal with the very important aspect of healthcare cost containment. So we try to change the conversation from how much we spend to how well we spend. And as we move out of this idea of using the sledgehammers to cut costs, we developed a concept called value-based insurance design, or VBID, which uses a scalpel to decide how we spend our money. So instead of just saying less of everything, cut costs on everything, how about an idea of doing more of the things we should be doing to make Americans healthier? Screenings, preventive care, management of chronic diseases, and instead spend less money on those things where the evidence is not so strong, where things are happening for incentives that are out of control and perhaps not making Americans any healthier. So what makes value-based insurance design different is the concept of clinical nuance. And what we mean by that is that the value of a clinical service is not just it's always high value or always low value, but it depends on who gets it, who provides it, and where it's provided. So for example, if you are over 50 years old, you should have colorectal cancer screening, maybe with a colonoscopy. If you're under 30 or over 85, you shouldn't. So the idea that we're trying to impress upon policymakers is things like MRIs are not always good or always bad. Coronary stents are not always life-saving or not always wasteful. That we have to take advantage of the clinical research body of information to make important policy decisions. And my view is almost all of the healthcare discussions going on, largely driven people who care about money and not health, have lost their way in the fact that it's all about dollars and cents and very little about the health of Americans. So these typical insurance products that people pay their out-of-pocket cost based on price are much different than value-based insurance design, or VBID, which is a concept developed at the University of Michigan, where we basically said, change the paradigm to basing the out-of-pocket cost based on price to setting the out-of-pocket cost for patients based on the amount of health that would be produced. So instead of now, where cheap things are cheap to patients, under value-based insurance design, or VBID, the things that are most important to the health of my patients, the things I beg them to do because I know how important it is to their well-being, those are the things that should be low cost to them. So value-based insurance design is a very intuitive idea, and it's been really interesting for me, having traveled to 49 states and talked to stakeholders across the entire spectrum of healthcare, patients to doctors to hospitals, now to consultants and policymakers, both at the state and national level. And when you go to anyone of their right mind and say, do you think it's okay that patients pay high out-of-pocket costs for drugs that are likely to significantly impact their lives? That patients have to go into bankruptcy or have a bake sale to get a drug that is targeted specifically to their condition? And we've been somewhat successful in going to Republicans and Democrats, management and labor, organizations who tend not to agree on too many concepts. And the good news is the status quo makes so little sense that an incremental idea like value-based insurance design that sets cost sharing based on value instead of price has had great success in terms of getting multi-stakeholder support. So the implementation of value-based insurance design, or VBID, has been a very slow and steady process. We first went and worked with large self-insured companies, ones that you've heard of, like Marriott or Dell, and talked to their leadership and said, you're really not getting the health that you should be getting out of your millions or sometimes billions of dollars of healthcare expenditures. And saying, I think it would be more important to encourage, not discourage, your employees and beneficiaries for getting the care they need. So we made a lot of headway in both public and private payers. And then the timing was quite good for us that we started to talk about value-based insurance design just when the United States was starting to get very serious about healthcare reform. And thanks to our University of Michigan government relations staff, these people brought us to Washington, D.C. to present our idea to both sides of the aisle. And lo and behold, there was great interest in the VBID concept, both from Republicans and Democrats. And this was a time where there's great contention and controversy and lack of partisanship around healthcare idea. We feel very fortunate that from the beginning, Republicans and Democrats agreed on value-based insurance design. The idea got swept up into conversations about the Affordable Care Act, or Obamacare. And VBID, in one way or another, was included in every bill in both in the House and the Senate as healthcare reform became a reality. And Republicans agreed with the VBID concept moving forward. The way value-based insurance design was incorporated into the Affordable Care Act, or Obamacare, is that for selected preventive services like immunizations, cancer screenings, and counselings, that Americans would no longer have to pay a penny to get these services. And this Section 2713 of the Affordable Care Act has impacted over 140 million Americans in the fact that their shots are free, their mammograms and colon cancer screening is free, they get screened for depression, diabetes, and other conditions to allow them to identify early treatable conditions. And we found this small part of the Affordable Care Act. Please don't get me wrong, it's a 900-page law. I love half a page. I can't say anything about the other 899 half pages, but Section 2713 has impacted so many Americans favorably. It is always, no matter what survey you look at, one of the most attractive aspects of Obamacare, and many people want to keep this idea of free preventive services in whatever might happen in the current political environment. You will find that not only supporters of Obamacare like free preventive services, but the most recent national surveys show that almost 80% of Republicans support preserving the VBID aspect of Obamacare in whatever we see moving forward. So once we had our momentum in the preventive services in the Affordable Care Act, we knew we also had to move forward in those folks who have chronic diseases. We didn't have time to include VBID in terms of managing chronic conditions like depression, diabetes, cancer, heart disease. And we fought very hard, again, mostly toward a grassroots approach, to further incorporate VBID concepts of high-value services should be low cost and low-value services should be higher cost in multiple settings. The biggest challenge for us was Medicare, because 98% of Medicare expenditures are not on screenings and prevention. Most people over the age of 65 have one, if not 7, 8, or 9 chronic conditions. When we tried to advocate to include VBID in Medicare, we learned quite quickly that in 1965, when Medicare was passed, there was something called the Anti-Discrimination Clause, that every American in Medicare had to have the same benefit design. This flies directly in the face of the VBID idea that some things should cost some people less and some services should cost some people more. So I was told by people in Washington that this would take an act of Congress, which I interpreted meaning get back on the plane and go home to Ann Arbor. But stubbornly, we persisted and continued to advocate in saying we need to try value-based insurance design in Medicare. We introduced bills in both the House and the Senate to allow a demonstration of VBID concepts in the Medicare Advantage program, and it actually passed the House, one of the very few bipartisan ideas to pass the House in 2015, and getting that signal that there was support from both Republicans and Democrats, the Obama administration approved a Medicare Advantage value-based insurance design demonstration in 7 states and in 7 chronic conditions, which began January 1 of 2017. And that's not all. The idea was so well received that even before the program launched, the Obama administration expanded the VBID Medicare Advantage demo to 10 states, including Michigan, which we fought very hard for, and expanded to additional diseases. Even more excitingly, as healthcare becomes the most partisan, rhetorical, and controversial issue, there is bipartisan support to expand the VBID MA demo to all 50 states. Both the House and the Senate have introduced bills in this Congress to allow value-based insurance design to be practiced in Medicare plans in all 50 states. We're very enthusiastic to see this movement, and that value-based insurance design is one of the very, 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 very few healthcare reform ideas that has support of both Democrats and Republicans in the U.S. political sphere. Yeah, you'd like to think that since people like the VBID idea that it's going to be included in everyone's health plan. And it turns out that that is very far from the case. We have been called the tortoise in the healthcare reform race, in the fact that value-based insurance design has made very slow and steady progress over years. And the biggest hindrance right now is the fact that the fastest growing type of health plan in the United States, called Health Savings Account Qualified High Deductible Health Plans, or HSAs, I'll call them, do not allow VBID principles to be used in anything besides preventive conditions. Because of an Internal Revenue Service regulation, which says you cannot have a service applied any type of insurance until you meet your entire deductible, which in some families could be over $10,000. You cannot use it for any service that takes care of an existing illness, injury, or condition. So that's those diseases that afflict so many Americans: diabetes, heart disease, depression, HIV. You can't cover insulin before you meet the deductible in a high deductible plan. You can't cover AIDS drugs before you meet the deductible in a high deductible health plan. So since that regulation was introduced in 2004, myself and the government affairs folks in the University of Michigan have been trying to persuade the Internal Revenue Service that this does not make sense. We're so glad that you're covering fully the preventive services that fall under our part of the Affordable Care Act, but it leaves out those services that I feel are equally, if not more important. So for 10 years, we've been fighting to change this regulation. And thankfully, we've had legislation introduced that we helped author to propose to the IRS that they must change the regulation to allow health plans to have the flexibility, not mandate, the flexibility to cover an additional amount of services in that safe harbor of not just preventive services, but chronic diseases. And I'll tell you that the support we have seen for this particular legislation has been extraordinary in its breadth across the spectrum of healthcare stakeholders. We are extremely hopeful that this current Congress and perhaps the Trump administration through the Department of Treasury will allow this change. Independent research has shown that this new type of high deductible health plan, which we call the high value health plan because it allows us to cover more things pre-deductible, would be taken up by at least 7 million Americans every year, will lead to better patient experience, certainly higher quality of care because people would access the services that would make them healthier. And maybe most importantly in this political environment, it would actually be a saver to the U.S. economy. And everyone's looking for something that would reduce the deficit to allow us to pay for other issues that cannot be afforded because of the fiscal restraints in Washington today. It's particularly frustrating for someone without any policy background or experience to go into so many of these settings and people say, this is a great idea, but I'm still not going to do it. And I think one of the things that's particularly challenging, but I view as an opportunity for us in value-based insurance design, is what's happening not on the consumer or patient side, but the intense attention, sophistication, and resources that are being afforded now to change the way doctors and hospitals and other clinicians practice medicine, moving away from fee-for-service to some type of alternative payment that's based on quality. So a primary care physician like myself, who previously was paid for everything they did, regardless of whether it worked or not, there are now arrangements that are saying, do more of these things for which the evidence is strong, and do less of those things for which the evidence is not as strong. So I am now, as a doctor, encouraged to do certain things, say like get my patients with diabetes to the eye doctor. And then we look, as we're saying, oh, I want to get more and more of my patients with diabetes to the eye doctor, we realize that more of our patients are enrolled in health plans that don't cover their visits to the eye doctor. And I go around the country basically shaming people and saying, how dare you incent me as a clinician to do certain things and enroll my patients in a health plan that don't allow them to do those things. So we have taken a very, I hope, intuitive policy tact that say, well, if we call the suppliers or the providers of medicine peanut butter, and my patients are consumers jelly, I want policymakers and decision makers to understand that when the doctor, peanut butter, and the patient jelly are aligned, the sum is greater than the individual parts. And we make this point to say, encourage both doctors and patients, nurse practitioners, physician assistants to do more of those things they should be doing, reward them for doing them, but instead of discouraging my patients by enrolling in plans that don't cover those services, why not create a health plan that makes it easy for my patients to do those things? And this has been a challenge and opportunity for us because changing the supply side or how healthcare is paid for in this country is the top priority of health policy. We make the point that whatever your goals are, quality, patient experience, or cost, if you align the patient with the clinician, you understand that the peanut butter and jelly is the greatest example of the sum being better than the individual parts. So for better or for worse, I'm known in Washington as the peanut butter and jelly guy, and I'm happy to be known as that as long as people understand that aligning both the providers and the patients is really the right thing to do if we want to get to where we want to be in spending our money wiser and making Americans healthier. One of the most humbling experiences that I have had moving forth over the nearly 2 decades on value-based insurance design is our experience dealing with the U.S. military and the Department of Defense. I had heard that those individuals enrolled in the armed forces and those people who serve at least 20 years, they're enrolled in a health plan called the TRICARE program. And because of budgetary constraints, the fiscal people in the TRICARE program were saying, we're going to have to make our armed services folks, their family members and retirees pay more for their health care, basically breaking a promise that they would be taken care of in terms of their costs. Luckily for me, a staff member in Washington had heard a line of mine, which is, if you're going to make people pay for something for health care, limit it to the things that they shouldn't be buying in the first place, which is a basic premise of the VBID idea. Good stuff, low cost, stuff you don't need. If you make people pay for them, those should be the things. I had the great honor to be called by Senator John McCain to testify in front of the U.S. Senate Armed Services Committee, where I made a pretty strong plea to say if TRICARE has to evolve to make the military folks pay for their health care, we could use it in this clinically nuanced way. Instead of cheap stuff cheap and expensive stuff more expensive, clinical nuance means the good stuff in the right setting, low cost, and make them pay for the things they don't need. I gave a testimony in February of 2016 and pretty much hoped for the best. Didn't hear anything until the day after Christmas when I got a call from the Senate Armed Services Committee staff saying, oh, Mark, by the way, there's a large VBID demo and TRICARE in the 2017 National Defense Authorization Act. It's already through committee, and President Obama is going to sign it into law before he leaves office on January 20th. So I sit here with goosebumps to think that a general internist from the University of Michigan and his colleagues have put together a concept that has not only made great progress in the commercial healthcare market, is already in the Medicare program with the possibility to expand to all 50 states. But on January 1, 2018, value-based insurance design will be incorporated into the TRICARE program, and some of the 9 million Americans serving in our armed services will have a health insurance product based on a University of Michigan idea.